let me start here. Welcome everybody. Thank you for attending. I will hope that you gain some insights about cataracts extraction in patients with uveitis. Last year we did some lectures and talked about the nature, diagnosis, and at least hit on a little bit of management issues regarding uveitis patients. Cataracts are a relatively common complication of patients who have uveitis. And when I say uveitis, I mean, I'm talking mainly about chronic uveitic conditions here. Acute uveitic conditions such as HLA-B27 associated hypopia, iritis, etc. Those kinds of things can cause cataracts, of course. Their management may be similar, but this most of this lecture refers to the more difficult patients who have chronic uveitis, chronic anterior chamber inflammation along with intermediate or posterior panuveitis, who have cataracts that obscure visualization of the posterior segment and interfere with the patient's vision. As with other, let's see here. Oh, excuse me. I've given away the answer here. So the first question that I have, and the answer is already given, it's actually going to be, I think I've given away the answer. The first question that we have is, in which of the following conditions is placement of an intraocular lens often contraindicated at the time of cataract surgery? And I'll talk a little bit more about this. Is it in patients who have Behçet's disease, patients who have recurrent HLA-B27 associated iritis or uveitis, juvenile rheumatoid or idiopathic arthritis associated uveitis, or toxoplasmosis? And we'll take a quick poll here. And I already showed you the answer that I was thinking of, but let's see what you guys think. All right, should we, so, yeah, so most people thought that yes, JIA associated uveitis, and certainly there are forms of Behçet's disease and severe recurrent HLA-B27 where we would be very concerned about putting intraocular lenses in patients as well. Here with children, I think there is a relative contraindication in some cases, and we'll get to that and we'll talk about some of the details of this in a moment. I'm going to go to the next slide here. The complications of uveitis are myriad, but cataracts and glaucoma and perhaps cystoid macular edema are the most common causes. Cataracts are much more common in chronic and recurrent inflammatory disease of the eye. And usually it's the combination of both the presence of chronic intraocular inflammation as well as the exacerbation of cataracts from the use of concomitant corticosteroids that result in cataract progression in many of these patients. But if you were to ask me which is more predominant, I would say in most chronic uveitic cases, it's the inadequate control of inflammation that really causes the development of cataracts. And when we see cataracts in uveitic patients, morphologically, most of these tend to be posterior subcapsular cataracts, the same kind of cataract that you may see with corticosteroid use. In addition, you obviously will have age-related nucleosclerotic changes and also climate and solar exposure related cortical changes that may be present as well. And we talk about surgical management when the cataract is visually significant or precludes the view of the posterior segment, which is required for monitoring the disease status. Okay, those are the two potential indications for surgery. In children, the risk factors for cataract surgery in uveitis are very similar. But again, if you look, it's the number of uveitis flares per year. This is based on some a recent study that from this year from the British group looking at, and the European group looking at a multi-center kind of approach to cataract surgery in uveitic in patients, children with uveitis. In these cases, the presence of cystoid macular edema, the number of uveitis flares per year, the presence of posterior synechia when the patient presents with disease, and the use of local corticosteroid injections all are significant factors. And interestingly, look where it says treatment with systemic and topical corticosteroids were not necessarily significant risk factors. Keep in mind that this study is a tertiary center-based study. where we're probably seeing a lot of people are uveitis trained, and so they've been managing the corticosteroids, systemic and topical, appropriately in order to try to reduce their contribution to the development of cataract. But more important than everything is that controlling the inflammation, even using higher doses of systemic steroids, is of importance in preventing ocular complications like cataract. So we can't lose sight of the fact that even though corticosteroids may contribute to cataract worsening, the most important thing that we have to do for our patients with chronic uveitis is to get the inflammation under as good control as possible for as long as possible to ensure that they will maintain long-term good visual outcome. There are some contraindications for cataract surgery in uveitis patients. If there's anything that I want you to take away from this talk, it is that if you have active anterior chamber inflammation in the patient and you're thinking about cataract surgery, you should put that thought out of your mind. Because cataract surgery in uveitis patients, with very few exceptions, is not routine. It's not something where you can do phaco, and not worry about them and send them out and not have to see them for a month after their first post-operative visit. They need to be monitored carefully because these patients will develop, even those who are well controlled, will develop post-operative inflammation in excess of what you're used to seeing in the typical patient. And these patients will need more aggressive pre- and post-operative intervention. The other contraindication, in addition to active anterior segment inflammation for cataract extraction in uveitis patients, is the presence of active surface infection. Somebody has a corneal ulcer, bacterial keratitis. If somebody has active herpetic disease in the cornea, obviously those are contraindications. And if they have concurrent ocular pathology that is likely to prevent functional improvement, even if with successful cataract surgery, that would be a relative contraindication. In those cases, surgery should be done only if it's necessary to allow visualization of the fundus to help improve the treatment process. So if a patient has decreased visual acuity that's explained by the cataract alone, they have inability to examine posterior segment in potentially progressive posterior segment disease. They have, in some cases, if the uveitis is caused by the lens, in other words, there is a traumatic rupture of the anterior capsule, and we're seeing a phaco-antigenic uveitis, in those cases, obviously we're going to need to do cataract surgery. You don't have to wait for the inflammation necessarily to be quiet. You also may need to consider the age of the patient. In a pediatric patient, especially a patient who's under the age of 10, we may have more urgent amblyogenic concerns about having a cataract. So if a patient has a cataract who's 4 years old and is significant visually and is really interfering with their vision, you don't want to leave that for several months because that will induce fairly dense amblyopia. But that also has to be tempered with the idea that good control of inflammation is necessary for adequate and good surgical outcomes following cataract surgery. So we like to, in many cases, in pediatric patients, try to defer cataract surgery if at all possible into middle or later childhood until the eye is more mature, until the uveitis has had a really good chance to be well controlled before we consider elective cataract surgery. There are many factors that complicate cataract surgery in uveitis patients, and here are a couple of pictures. I apologize for the little bit of horizontal parallax distortion in the images, but I think you get the idea. The presence of posterior synechia. Obviously, you don't have a nice, round, beautiful 8 or 10 millimeter pupil to be working with and doing cataract surgery in these cases. Sometimes the pupillary dilation is extremely poor, as you see in the lower right. You may see epilenticular membranes, as you see in the lower right. You may see calcific band keratopathy, as you see in the lower right. The cataract may be white and mature, as you see in the lower right. And the lens may be hypermature, as you see in the lower right. So this patient has a very dense white cataract. You can see that there was a peripheral iridotomy that was performed previously for iris Bombay that they had in the lower right. The upper right picture, you see this patient actually has 3 areas of posterior synechia, moderate dilation of the pupil. These synechia will need to be broken at the time of surgery. Notice the patient has an iris nodule here, so they may not have good complete control of their inflammation. The band keratopathy I mentioned. Fibril iris vessels, as you see in the picture on the lower right. You can see this. These are vascular anomalies within the fibrous membrane that is secluding and occluding the pupillary plane here. And then you'll see the calcific band keratopathy in the upper right. The anterior chamber may be shallow, and you can't see it, but the lower right picture is the shallow anterior chamber. And the lower right also is a patient who has very profound hypotony already. Pressure is 4. And prior glaucoma or vitrectomy surgery, they may have weak zonules or zonular dialysis because of chronic intermediate uveitis, where there's inflammatory cells on the zonules that have caused some gradual weakening of the zonules. This is a typical patient with a dense white cataract. You can actually see ectropion uvea as their pupil is tended to be dilated, and they have 360 degrees of posterior synechia, and probably a very thin pupillary membrane is also present, occluding or secluding the pupillary plane. In this case, this patient will require fairly complicated cataract surgery, assuming that their anterior chamber inflammation is completely quiescent on therapy. Here's another close-up of those friable iris vessels. You also need to assess in these patients what's the back of their eye look like. Preoperatively, we need to make sure that the lens opacity is the main cause of the reduced vision. If the patient has severe cystoid macular edema, as you see in the pictures below, or they have severe glaucomatous cupping, as you see in the lower right, where you have significant loss of the nerve fiber layer substance and a very thin neural rim, these things are going to interfere with the visual outcomes. And you need to have a good idea of telling the patient what to expect if cataract surgery is indeed planned, or you may decide that cataract surgery will not be appropriate because of these other underlying problems. The presence of active cystoid macular edema like this, to me, would be a relative contraindication to proceeding with cataract surgery, because I know after cataract surgery, this cystoid macular edema will become more severe and very recalcitrant to treatment and will result in severe vision loss. Here's our next question. I won't give away the answer here. So here, in a patient with a history of scleritis and vision loss, the clinical appearance shown, what measurement would be most important prior to considering cataract extraction? Corneal pachymetry, retinoscopic refraction, dilated fundus examination, or intraocular pressure check? Now this is kind of a tough question because it's kind of like, think what I'm thinking. We'll give you a few seconds to answer. So this is a patient with scleritis. All right. So, you know, the answers here. So yeah, I think all of these, this is kind of a tricky question, but none of you got this right. This is interesting. So all of these are very, very important. But I think if you were to ask, well, let's say that I should have said, well, you know, the fundus examination is normal, or the intraocular pressure is normal. Corneal pachymetry is, you know, reveals some odd, or reveals normal, doesn't show any abnormalities, but the topography may reveal irregular astigmatism. So a retinoscopic refraction, if a patient has reduced vision as a result of this, a retinoscopic refraction actually is the thing that we're thinking about, because a retinoscopic refraction will result in for you finding out that that patient who has irregular cylinder actually refracts to 2016 or 2015. So think about that in patients who have scleritis, because as the scleritis goes away, as you see here, and there's, you know, thinning of the sclera, you will see also some changes in the axis of astigmatism that may have a profound impact on the patient's refractive error and may not require surgery. Now, in a patient with scleritis, you can still do, in inactive scleritis, a clear corneal approach to cataract surgery, and many patients with inactive, well-controlled scleritis will do extremely well with cataract surgery. So I apologize for the rather obtuse question here. All of those answers are necessarily not incorrect, so none of you are incorrect in your thoughts. But in this case, we were thinking about the possibility that retinoscopic refraction may tell you, you know, immediate. So don't overlook the simplest things that we can do for our patients. So consider PAM or laser interferometry to determine predictive visual outcome if you can't necessarily get a good view of the posterior pole. Obtain an OCT. Sometimes an OCT will show you much more information in the macula about CME than you can glean from a binocular indirect ophthalmoscopy examination or a slit lamp examination. And you need to counsel the patient about managing their expectation, the possibility of a limited prognosis. You need to discuss why we're doing the surgery. You know, what is the expected outcome, and the prolonged follow-up and the increased need for medications in the perioperative period, and the likelihood that additional procedures such as post-operative injections, imaging, lasers, etc., may be necessary more than their Grandpa Joe who got cataract surgery and got 20/20 the first post-operative day and never had to take any drops. These are, you know, these patients, we have to manage their expectations, and I think that's very, very important. The threshold for cataract surgery in uveitis patients is very different, I think, than the routine cataract surgery patients. You know, if you have 20/25 vision with glare, that's rarely an indication for surgery in a patient with severe uveitis because the risks are greater. So when like any surgery, when we weigh out and balance the risks versus benefits, we have to make sure the benefits outweigh the risk before we can be an advocate for suggesting surgery for a patient of any kind. So we often require periocular steroids, immunosuppressive therapy, and that incurs additional risk, intraocular pressure issues, immune suppression, increasing the risk of post-operative infections, etc. Those kinds of things we need to think about. What are the general principles? What do you need to do beforehand? So this is the second point that I want you to take away. The first point is cataract surgery in uveitis patient is almost never routine, okay? The second point is that when you're treating patients with chronic uveitis, you need to make sure that the eye is quiet. That means no inflammation. But that doesn't mean off of all medications. Whatever it takes to control the inflammation, you need to keep them controlled with no cells, in my opinion, in the anterior chamber, okay? And baseline flare. And if you can keep them quiet that way for 3 months without a flare, then you have at least some likelihood that you're going to have reasonably good control of inflammation pre and post-op. Because the control of the inflammation pre-operatively and post-operatively is going to have everything to do with your surgical outcome, okay? It's not how good and fast you are doing phaco. All of you guys, I'm sure, are fantastic phaco-emulsification surgeons and cataract surgeons, but it's more than that. It's about the medical management of these patients before and after surgery. So in the upper right-hand picture here, you see a patient who has sarcoid anterior uveitis, and you can see both Kepi nodules and also these Busaka nodules. And you see posterior synechia in nearly 350 degrees of the iris. And in this patient, they're not well controlled. They're not ready for cataract surgery. In fact, their lens looks reasonably clear. They're a relatively young patient here. So this patient will require very, very good control of inflammation. All the nodules will essentially be gone. You shouldn't see any anterior chamber cells, etc., when you're looking at these patients. And they need to be that way for at least 3 months. And I would kind of say, you know, 3 to 6 months. So you need to optimize that uveitis status prior to surgery. Treat the cystoid macular edema because that's going to get worse after surgery. And treat the anterior segment inflammation because if you don't, you're going to have a worse post-operative results. So quiet eye for at least 3 months, and the patient should have an examination, perhaps even the day before cataract surgery, or very shortly before cataract surgery. Make sure the eye is quiet, okay? And if you have good control of inflammation, you're talking about, based on recent data in JIA patients, for example, their likelihood of being 20/40 or better if they have well-controlled inflammation is 71% compared to those who were not well-controlled, where, you know, that only 22% were better than 20/40 after cataract surgery. So these good visual outcome is proportional to good control of inflammation. So prior to cataract surgery, many of us will have increase in perioperative oral and topical corticosteroids. Now there's some controversy. If the patient has not taken oral corticosteroids prior and they've been controlled just with topical agents, I often will just defer to using frequent topical agents, and I will use prednisolone 1% drops or Durezol, if Durezol is available, very frequently. Durezol every 2 hours or prednisolone every hour, starting 1 week before cataract surgery, and then gradually tapering the topical drops based on the postoperative inflammation. And these patients should be monitored weekly this first 4 to 6 weeks after surgery. In addition, in patients who are on systemic immunomodulatory therapeutic agents and low doses of oral corticosteroids, or if they've required oral steroids in the past, I will start them on 40 milligrams of oral prednisone and I'm not trying to be dogmatic, but generally it's between 0.5 to 1 milligram per kilogram per day. So about 40 milligrams of prednisone starting 1 week before surgery, continuing the week after surgery at the same dose, and then gradually tapering weekly to every 2 weeks based on their inflammation of the oral prednisone as well, back down to their baseline level of prednisone. That is my pre-operative and post-operative management in a nutshell. So that's the second thing that I want you to take away from this talk. Appropriate pre-operative management, quiet eye for 3 months before you consider surgery. Don't even think about surgery if the eye is not quiet. So there is an interesting study recently that looked at whether or not, and it was a randomized controlled trial, so I think that this is good data and it makes sense. So people who had, people were treated who had chronic uveitis who were getting cataract surgery, and they had about 50 patients in each group that were randomized, one for oral plus topical, one for topical alone, and they had very similar outcomes in this study. Again, this is a two-center uveitis specialist-driven kind of approach, and so in these cases, please keep in mind that, you know, again, we're not talking about general ophthalmologists doing these studies, so these are ideal circumstances. So these patients are already well controlled, and these patients had good pre and post-operative control or on appropriate therapy for chronic uveitis management. So intraoperatively, there are many considerations, and I'm a retina surgeon, so I'm going to admit that when I do cataract surgery, it's usually a pars plana lensectomy approach, and there are some cases of pediatric uveitis or chronic uveitis where pars plana lensectomy is the right approach. So my approach is very different than the anterior segment surgeon, obviously. But for the anterior segment surgeon who's doing an anterior approach for cataract removal, you need to, since the eye is quiet, you can then do a clear corneal wound. That's preferred, especially in patients with scleritis. Obviously, you don't want to do a scleral tunnel in a patient who has, who's had previous scleritis. So clear corneal wound, temporal approach is fine, whatever you like, depending, again, if there's sclerokeratitis or corneal thinning in certain areas, you want to try to avoid that. You want to go in and remove pupillary membranes. You need to do synechiolisis and then stretch the pupil. Often we use iris retractors or a Malyugin ring, depending on how easy each of those is to get in. We then do a capsulorhexis that's rather broad and wide, and make sure that we do a complete cortical cleanup. And if you're going to put an intraocular lens implant in the eye, it must be intraocular lens implantation in the bag. And generally, I use acrylic or PMMA lenses. I will not use silicone lenses. And in fact, as a retina specialist, I really don't like silicone lenses for obvious reasons. If I have complex or retinal detachments, I don't want to have, even in the routine cases, silicone lenses are wonderful lenses, but they're not really suited for the retinal surgeon and potential complications of retinal surgery. But acrylic and PMMA only. And generally, I prefer, rather than the single-piece acrylic, I like the 3-piece acrylic, but you know, that is my own preference. As a retina specialist, I see more complications and problems with the acrylic single-piece foldable lenses. But again, as long as they are in the bag and you get appropriate contraction of the capsular bag, those acrylic lenses won't go anywhere. But early in the postoperative period, I have seen many acrylic lenses that were thought to be in the bag that were not. One haptic was actually tucked, and the knee of the haptic was rubbing against the iris. There are lots of little things that can happen with that, whereas with a 3-piece acrylic lens, typically you'll have Proliene haptics, and you're able to adjust those haptics fairly easily and have good seating of this. And with a single-piece PMMA lens, it's going to be relatively easy to get that in the bag as well, but you need a larger incision. And I like PMA lenses as well. Intravitreal triamcinolone can be given transpars plana or even through the anterior segment if you want at the end of the procedure. Generally, this is very helpful for the management of the inflammation postoperatively and cystoid macular edema. So again, posterior synechia may be present and pupillar dilatation and epilentic membranes, as I mentioned. The white cataract and hypermature lens is often found as well. How do we decide intraoperatively or preoperatively whether the patient to get an intraocular lens? That is another difficult question that I'll come to towards the end of this talk a little bit more here. If the patient has band keratopathy, that needs to be addressed, obviously, so you can have good visualization. So the band keratopathy procedure should be done first and let the patient heal first from that. Doing band keratopathy removal with chelation with the EDTA scrubs, that potentially could be problematic. If you're going to do cataract surgery at the same time, I wouldn't advise it. I think the band keratopathy should be taken care of first, and then the cataract after that, after the cornea is healed. Synechiolisis we'll talk about in a moment. Peripheral iridectomy or iridotomy may be required to gain access to the pupil, and excising epilenticular membranes will require a fine Utrata or intraocular 25-gauge forceps. Pupil stretching with iris hooks or Malyugin ring may be useful, and of course trypan blue staining the capsule is useful in these dense cataracts. So clear corneal surgery is nice, especially in scleritis patients. You can avoid contact with the sclera and leave the conjunctiva alone if you're going to consider future glaucoma procedures. A couple of things surgically, and these are things that my colleague Deborah Goldstein has put together. These are really nice little drawings of how we approach patients who have who need cataract surgery in uveitis. And when we see somebody who has 360 degrees of posterior synechia, how do we get at these synechia from the anterior chamber? You know, if you've ever just entered the anterior chamber in hopes that then using a small iris hook, or perhaps using a Sinskey hook, and to try to hook the edge of the iris and try to stretch the iris, you often will find a pupillary membrane, and that membrane needs to be removed first, and it's very difficult to pick up that pupillary membrane and remove the membrane. And the other thing is that the posterior synechia are not just at the margin. This chronic inflammation has affected the whole iris, so often these synechia will have broad adhesions, and not only at the pupillary margin, but there may be adhesions that go on to the mid and far peripheral iris as well. So generally, one good way to do is to make a small peripheral iridotomy superiorly. That will come in handy later, and this is a superior approach. And then using an iridodialysis spatula, go underneath the iris and then very gently sweep the synechia off the surface of the lens capsule. And this can be very, very effective. And once you do that, this will actually allow you to see the pupillary membrane. You can make a rent in the pupillary membrane from the posterior to the anterior chamber, or you can go back in anteriorly with the Utratus or other forceps and peel that lenticular membrane off. Once that's done, then you're ready to stretch the pupil. And you can use iris hooks. I really like iris hooks. As a retina guy, I don't use the Malyugin ring very often. The iris hooks are nice, 3 small self-sealing clear corneal incisions, and they're self-retaining, and they provide a nice surgical square pupil with broad area of exposure. So you can use the capsular dye to create the capsulotomy, especially in a white cataract. Here's a Malyugin ring being placed in a patient who had synechia. This is the initial photos in the upper left, and you can see her doing this surgery intraoperatively. Sometimes you can see significant zonular disruption or dialysis. In these cases, you need to think whether or not is it safe to continue surgery. So look at the picture in the, look at the picture here in the lower right, and you can see here this patient has tremendous zonular disruption. Even with appropriate, she's using specific capsular hooks here and holding the capsular bag in place while she's doing the capsulorhexis. This can be very problematic, obviously, once the phaco is done and the lens has been taken care of. How do you then manage the intraocular lens placement? You're going to have to use either some sort of a capsular support system or probably get this intraocular lens in the bag and then try to center it. And the centration may be very difficult because that might require you to suture the lens into the sulcus. Again, any manipulation of uveal tissues, the more you do manipulation of the uveal tissues, the more you're going to see post-operative inflammation and post-operative problems. So in the one in the lower right here, in this case, it might have been even better just to do a parasplenial lensectomy and leave the patient aphakic. But I can see why she's encouraged in wanting to do this, because there are no synechia. There's not really a lot of structural damage to the iris. So in this case, she has opted to, and this patient did very well. had anterior segment surgery and had a capsular tension ring placed along with, and I think this was sutured ultimately into the sulcus with at least one suture holding it in the sulcus, and the patient did very well. Tension rings can be utilized, but remember that these go in the bag. I have retrieved a few tension rings in the, from the retina in the past, so you got to know exactly where the capsulotomy is and make sure that you have the ring inside the bag. It does no good if you can't see how the ring is being placed and you don't get into the equator of the capsular bag. So the trypan blue can also be utilized as well to expose the anterior capsule and make it nicer to see the anterior capsule. We already talked about the intraocular lens. So in the bag location of the intraocular lens is the preferred one. Sulcus intraocular lenses, you know, can be used. There is probably some greater risk of developing iris shaping and rubbing if the inappropriate lens is used. You cannot use a gummy bear or a single piece acrylic lens in the sulcus. It even says that in the package. This is not for sulcus placement. So you have to use a 3-piece acrylic if you're going to do that, or a PMMA lens. And I would suggest that if you know, if there's vitreous loss, etc., and things aren't going well and you can't put it in the bag, either not put a lens at all or do a thorough vitrectomy and then put a PCIOL. You may have to suture the PCIOL into the sulcus if it's insufficient capsular support. And again, this can carry with it a much greater risk of intraocular hemorrhage because these are inflamed eyes, greater risk of postoperative inflammation. All of this that we have to kind of weigh out, and unfortunately, intraoperatively, we're kind of, you know, stuck making decisions on the go. But remember, pre- and postoperative inflammatory control is going to determine outcome. We definitely want to avoid anterior chamber intraocular lens placement because that's going to cause chronic iritis, and that's exactly what we're trying to prevent the flare-up of after cataract surgery. Typically, because we're using frequent topical corticosteroid drops, there's usually a need for wound closure. So there's going to be inhibition of wound healing. So you should put a stitch to make sure that the wound is closed, even if it looks watertight. I'd be cautious. The patient is a greater risk for wound leak and potentially infection. Don't give in to peer pressure. This is kind of a blurry cartoon from Larson, but don't give in to peer pressure of saying, well, I'm just going to do phaco and I'm going to put, you know, use whatever lens I want to use. You have to kind of do this in a measured way when you approach cataract surgery in uveitis patients, because not everybody needs to get an IOL. I have many patients who are aphakic, who had very severe inflammation, who underwent cataract surgery, who are doing extremely well with 20/20 vision with appropriate aphakic contact lens correction. It's not ideal, yes, I agree. But there are many children with, young children with uveitis over the years that I've done vitrectomy, lensectomy on that are inflammation-free, many of them off of medications, doing well. So patients who have extensive posterior synechia, and particularly patients who have significant flare or hypotony or have history of non-compliance before these 3 months of control and they've not been well controlled, these are the cases where I'm going to think long and hard about using an intraocular lens implant. And, you know, if they've failed an intraocular lens in their fellow eye, meaning that they have a cocooned lens or the lens required explantation because of persistent inflammation, in those cases, leave the other eye aphakic. That is my approach. Now, being in the 21st century, you may say, wow, that's crazy, you leave people aphakic. But you know, I would much rather have an aphakic patient wearing a contact lens with 20/20 vision than I would have a pseudophakic patient with a cocooned lens and hand motions vision, where I have to go in and remove the lens, and they're at risk then for developing other complications from the lens removal, such as retinal detachment and intraocular hemorrhage and all kinds of other nonsense. So the risk of intraocular lens placement, you know, in uveitis patients, what are the things that what would happen? We put in the intraocular lens and all heck breaks loose and all the inflammation goes awry. What's going to happen? Well, dense intraocular lens precipitates are going to develop. Cyclitic membranes will develop in the ciliary body and around the zonules. And the cocoon, the IOL will become cocooned. it will actually be surrounded by white anterior and posterior capsular fibrosis, and you will see ciliary body detachment and probably irreversible hypotony. And I have a few patients where this was a uveitis patient had surgery and this happened. So this is not something to take lightly. This happens more frequently than we know, but we're seeing it less commonly now because we have many more drugs. We have more aggressive uveitis specialists who are controlling the inflammation and getting the patient teed up for the cataract surgeon to have appropriately good outcomes with cataract surgery. So in JIA, there's some controversy. As I mentioned in my first question, that's the one case where, if you're going to leave a patient aphakic, you're going to more likely do that. So people who are younger, who have extensive posterior synechia, who have a lot of flare, the proteinaceous flare in the anterior chamber, I'm going to leave aphakic. The more flare you have, the more likely you are to develop cocooning of the intraocular lens implant. You will have early post-operative fibrin formation in the anterior chamber, and you will likely have cystoid macular edema in those patients, in my experience. So, patients who have hypotony, et cetera, those people are not going to do well with an intraocular lens implant. So people who are older, who have well-controlled inflammation, good compliance, and who don't have a lot of synechia, don't have a lot of flare, and have a significant cataract, those people are going to do well. So here's some inflammatory deposits on the intraocular lens implant. You can YAG these off, but they'll come right back if the inflammation is not well controlled. So the YAG laser can be used to actually brush these off. It's kind of fun to do, but it's just, you can't keep doing it. And here's a patient that got epilenticular membranes and a lot of synechia following cataract surgery. You're still seeing okay, but look at that. He's syneced down almost all the way around the eye. Even all this area is syneced to the posterior capsule, or anterior capsule, I mean. And so you see these fibrinous membranes. So this patient had a lot of fibrin post-operatively, immediately post-operatively, that led to those fibrinous and fibrous membranes on the surface of the lens. Here's a cocooned intraocular lens implant. And many of us have seen patients like this. These patients have a very poor visual prognosis, will require explantation of the intraocular lens. If they're not hypotenuse, we might be able to open up that capsule posteriorly, and they might need a vitrectomy. They're at greater risk with vitrectomy for developing retinal detachment as well, because many of these patients will have a detached ciliary body and an altered anatomy of their pars plana, pars plicata area where a retina surgeon might put his instruments. So post-operatively, control inflammation aggressively. Sometimes I have used intracameral TPA. I've done that a few times over the last several years, where somebody develops severe fibrin in the anterior chamber. TPA works very beautifully. Usually you see it in the first 1 or 2 days post-operatively. Remember, you have to make sure this fibrin is not from like an endophthalmitis, obviously, right? So this is sterile fibrin. You'll see it. It'll be very congealed, and the eye will look relatively quiet, but there's just a lot of fibrin in the first couple of days. There's no hypopion, usually in this case. And we give intracameral TPA, give them about 12.5 micrograms, 25 micrograms in 1/10 of a cc. And that usually breaks that up immediately. Within 12 hours, it's gone. It's pretty remarkable. And it can be very, very helpful in cases where there's a lot of, this fibrinous inflammation. This happens more commonly in patients who have a lot of pre-existing flare. It may happen more commonly in children. And then, of course, cystoid macular edema, we need to use the topical nonsteroidals, and aggressive use of intravitreal, periocular, and/or oral corticosteroids as well may be helpful in these cases. So again, the important things to consider are good preoperative and postoperative control, set reasonable expectations, anticipate intraoperative techniques and equipment, control inflammation for at least 3 months before surgery. Intraoperatively, consider a PI, suture the corneal wound, and manage the pupil membranes and zonules appropriately, and then place the intraocular lens in the bag if at all possible. And then these patients need to be followed post-operatively much more frequently, because you can have these kinds of complications you see on the right, where the intraocular lens is actually has been displaced, it's scarred, it's pushing against the iris. There's no, you can see the edge of the haptic here, and this is a disastrous outcome following cataract surgery. These patients need to be monitored, the fundus, and aggressive control of the inflammation is necessary. Which of the following preoperative parameters is the most important predictor of post-operative outcomes after cataract extraction in uveitis patients? So the presence of band keratopathy, presence of glaucoma, presence of anterior chamber cells, or presence of posterior synechia. So which of the following preoperative parameters is the most important predictor? Let's see what you guys got. Yeah, so the presence of anterior chamber cells is really the main predictor so if the patient has active inflammation, you know, that's the situation where you're going to not do cataract surgery because you want the eye quiet for 3 to 6 months beforehand. You know, the encouraging thing is that under appropriate management, in the MUST trial results most recently this last year, looking at all of the 479 enrolled eyes, 117 underwent primary cataract surgery. In this controlled clinical trial, the patients overall did very well. And these were patients who were managed by uveitis specialists who were participating in the study. In this multi-center randomized trial, we found that no matter whether they were on implant or whether they were receiving systemic immunosuppression, and this MUST trial actually is looking at and continues to look at which treatment is better. Is it better to have patients with chronic uveitis on systemic immunomodulatory therapy, or is it better to treat them with a fluocinolone implant? And the 7-year results have shown us that probably the systemic medication group actually will have a better visual prognosis with about 7 letters of better visual outcome after 7 years of treatment compared to the implant group, okay? But when you look at cataract surgery in these patients, that no matter which group they were in, whether the systemic therapy or the fluocinolone implant alone, these patients had good outcomes because these patients had good control of preoperative and postoperative inflammation, and their overall letter gain was 23 letters, so most of them had substantial visual improvement following cataract surgery. So overall, with appropriate control, cataract surgery is a very good visual prognosis for patients with uveitis. You know, and if you look at all of the multi-centered kind of approach, uveitis accounts for a very small minority of patients who undergo cataract surgery. We're only about 1 to 2% of patients who have cataract surgery. And the eyes in the uveitic group usually had a worse preoperative visual acuity, according to this British study. And there were younger patients, shorter axial lengths, that had a higher incidence of co-ocular pathology, including glaucoma and small pupils. And they required additional surgical procedures and had developed more intraocular complications. And compared to the general cataract surgeon, these patients tended to have poorer postoperative visual acuity at all follow-up up to 6 months. So that's important to keep in mind too. So the outcomes of these patients, although good and definitely can be very good with appropriate control, overall still are a little worse than the typical cataract surgery patient. I hope I haven't bored you with all the information. I think I'll stop at this point and maybe take a few questions. I think we ended right at about 42 minutes or so. So I will see if I can get at the get back to the chat screen here, and we'll see if we've got. I wanted to ask if there was any questions, and I'm happy to answer them at this point. I appreciate your interest. So yeah, so let me start at the top here. The first question from Dr. Mehta was, what if there are vitreous membranes associated with JIA, idiopathic arthritis? Do you do a vitrectomy associated with cataract extraction, risk of doing and going into ciliary shutdown? And that's an excellent question. So if the patient has significant vitreous opacities, yes, we often will combine vitrectomy with cataract surgery. So and this can be done in a staged process, or in the case of children, since you're putting the patient under general anesthesia usually to reduce anesthetic risk, this can be done together. So the same surgeon or perhaps a retina surgeon can come and do the vitrectomy portion of the procedure. And this can be done after the cataract has been removed, prior to the placement of the intraocular lens implant, or you can do the vitrectomy first if there's reasonable visualization and then remove the cataract and do the anterior segment work. I think it depends on what we find, what is going on with the patients clinically. So removal of the, and doing a pars plana vitrectomy, in my opinion, when we do cataract surgery can be very beneficial too for inflammatory control of patients, particularly in patients who have intermediate or pan-uveitis. This may be very helpful. So the next question was, let me see if I can get them in order. There's a lot of questions here. Who would you put on an IOL in a quiet posterior toxoplasma inspection? Or would you put an IOL in the, if you had somebody with posterior toxoplasma retinochoroiditis that's inactive with a perimacular scar, in those patients, I generally will put them on some sort of Septra prophylaxis prior to surgery if they're not on it, and then go ahead and proceed with routine cataract extraction. I would not expect that that patient should have any major problems. Why in juvenile idiopathic arthritis is intraocular lens implants contraindicated? They're not always contraindicated, but patients who have extensive posterior synechia, chronic flare, poorly controlled inflammation, poor compliance, those patients you should avoid intraocular lens placement. An intraocular lens, regardless of how you look at it, is still a foreign body in the eye. If somebody has poorly controlled inflammation, they're going to do well. They're not going to do well after cataract surgery because that's just going to make their inflammation worse. So very aggressive, good control of pre and post-operative inflammation is the key, and you have to have that before you do cataract surgery. So acrylic over PMMA, which lens do I prefer? I think that both are good. Again, I told you that single piece acrylic lenses, you have to make sure that when you put them that they are, both haptics are in the bag. There's a tendency for the knee of the single piece acrylic lenses sometimes to bend and not, and to come out of the edge of the capsular bag, especially the inferior part. If that happens, that can rub against the iris and create chronic inflammation, and it really creates a real problem post-operatively. So you got to make sure that the IOL is in the bag. And if you're using a larger capsular rhexis, using a three-piece acrylic lens might be better, or using a PMMA lens might be better because these are less likely to migrate. Intracameral dexamethasone, intracameral triamcinolone, and posterior segment triamcinolone can be very useful. I use triamcinolone. I typically won't give intracameral dexamethasone. If you do that, I don't think that that would be of any great harm. Again, remember, these patients are at greater risk for infection, so you need to be considerate of that, especially if they're on immunosuppressants. Is there any concern with corneal wound healing in patients with scleritis? Should we put suture in those patients? If you do put sutures in patients who have previous scleritis, I would avoid going through the sclera, deep into the sclera. And again, generally in uveitis patients, a clear corneal wound is utilized in patients who have previous scleritis. And if you can't put a suture, or if you think you're going to have to get into thin sclera and cause problems with that, you can avoid the suture. But generally, I would try to put a suture through the clear corneal wound. And do we do it routinely in uveitis patients? We do. I just think that why take the risk of wound leaks? Why take the risk of hypotony? Why take the risk of endophthalmitis in those patients who are at greater risk anyway? LASIK and aphakic uveitis patients, indications, contraindications. Well, LASIK for aphakia, as far as I know, is still, because if we're trying to correct +10 diopters, etc., it may not be very successful. We may have inadequate correction of that level of hyperopia, induced aphakic hyperopia. So I don't know that I know the answer to that question. I don't know that there is any specific contraindication, but anytime we do any kind of ocular procedure, especially in JIA patients, we have to be particularly careful of flare-ups. I have seen patients who have no active inflammation who underwent calcific band removal who had flare-ups of inflammation of their anterior chamber. So this is very, very important to remember that take no surgery on especially a JIA patient, lightly, because these patients can have flares with minimal intervention. So the next question is preoperative predictor of visual outcome for cataract surgery and uveitis. So the question for preoperative outcomes, when we look at patients who have bad flare and uncontrolled inflammation, they're going to have bad postoperative outcomes. So preoperative factors that really impact outcomes are good control of inflammation. They should have any cells in the eye, okay? if they have a lot of flare, you can still do surgery, and they don't have cells, and they've been quiet for 3 or more months, you can still do surgery, okay? But those patients will have a greater likelihood of fibrin development postoperatively, development of cocooning of the intraocular lens, development of chronic cystoid macular edema, and persistence of flare and development of hypotony. Keep that in mind. If they have dense flare, not much cell, and they're already kind of lower pressures and they have a dense cataract, those patients are probably better off to have a pars plana lensectomy, vitrectomy approach rather than an intraocular lens. So let's see, let me see. Would you use intravitreal steroid implant before or at the time of surgery? I would say that if the patient has active inflammation and you're using an intravitreal fluocinolone implant, put the implant in, get the inflammation controlled, and then do cataract surgery. Remember that according to the fluocinolone implant study, that the Retisert causes, in the vast majority of phakic patients, 90% will get a cataract within the first 2 years of the implantation and will need cataract surgery. So that's a done deal, but you want to have inflammation controlled for at least 3 months with no cells before you do cataract surgery. Do we need antibiotics for infectious uveitis preoperatively? You know, if you have an infectious uveitis patient that's controlled and treated, I still am careful and cautious. I have patients on prophylactic antibiotic therapy if they have toxoplasmosis, for example. As I said, I will use some prophylaxis with oral Septra Bactrim initially. Sometimes I may give, if they've had recent episodes of toxoplasmosis, intravitreal clindamycin. If they've had a previous history of syphilitic uveitis, I may consider giving them an injection of intraocular ceftriaxone or some cephalosporin or even vancomycin. That might be not an unreasonable thing to do, but that's not required. That's just a personal preference. As long as the inflammation is quiet and you've taken care of the infectious component previously. In patients with uncontrolled IOP, preoperatively, can we combine TRAB with cataract surgery? Yes, in a uveitic patient, when that happens, you can do that. Generally, though, I will tell you that TRABs tend to fail. We'll talk about this as the next lecture in a couple of weeks. But trabeculectomies fail in uveitis more often than not. So generally, when we're doing this, we're considering a tube shunt placement in the patient, such as a Maltino tube or Barvelt implant or a Ahmed implant, and cataract surgery simultaneously. That is a big surgery, especially in uveitis patients, JIA uveitis patients. And those patients will have much more inflammation and many more postoperative problems. There are more risk for choroidal hemorrhage. There are more risk for malignant aqueous misdirection and other complications that can occur in the face of combined surgery. So keep that in mind. Cycloplegic should be continued in the pre- and post-operative period. It's very, very important to use cycloplegics in these patients to prevent posterior synechia formation. However, if the pupil's very large after surgery and didn't have synechia, if you leave them on atropine for a long time, you can end up with a pupil that's stuck to the capsule in the periphery, and that's not good. Then you have a very widely dilated pupil. So you need to use milder cycloplegics after the initial first week or two of using strong cycloplegics. So you need to modulate even the cycloplegic therapy. Would you do goniosynechialysis? Yeah, obviously, if there's angle closure, and yes, if I'm already manipulating the iris and removing synechia, you can certainly add that at the time of surgery. It may or may not help you with intraocular pressure control. You know, advice about steroid responders and increased IOP. Obviously, yeah, when you're going to increase their use Durezol every 2 hours and you already have a steroid responder, their pressure is going to become very high. Control the pressure the best that you can, because tantamount to good outcome is good intraocular inflammation control. So inflammation control takes precedence to some extent over intraocular pressure control. We don't want to get dangerous levels of intraocular pressure control problems. So if you end up in a situation where the inflammation is well controlled, the IOP is very high, and they've got a cataract, glaucoma control maybe, and glaucoma surgery may be more important if they're on maximum medical therapy. You might want to do that first before tackling the cataract. So this will, do you prefer intravitreal or systemic? My personal preference is systemic therapy. The MUST trials have shown in general that these two entities are equally good, but in chronic bilateral inflammatory disease, these patients require therapy for more than 5 to 10 years. Implants last 3 years. So in my humble opinion, systemic immunomodulatory therapy is the better way to go. The quality of life outcomes and now the visual outcomes seem to be as good or better than the implant. The likelihood of needing surgery, cataract surgery, glaucoma surgery, those kinds of things are less in the patients who have systemic immunomodulatory therapy compared to the implant group. Heparin-coated lenses have been shown, heparin-coated intraocular lenses at cataract surgery have been shown to be beneficial and reducing inflammation in the post-operative period, reducing fibrin formation. So there is some role, but most uveitis specialists in this country are not typically using heparin-coated lenses. They don't go out of their way to do that. And so most are relying on good pre- and post-operative control of inflammation. Patients with intraocular pressure elevation prior to surgery, do I use acetazolamide? Certainly. I rarely use mannitol intraoperatively if the patient requires some kind of control of their intraocular pressure. I might use mannitol, but I have not done that in 25 years. So generally, the topical agents and good control of intraocular pressure prior to surgery is important. You don't want to be facing a patient in surgery with a pressure of 50 and no inflammation, because their problem is not their cataract at that point. Their problem is glaucoma. So you have to remember, glaucoma, cataract visual loss is reversible. Glaucoma visual loss is not. So that's how you need to organize your thought processes and how you're going to manage these very complex patients. So I hope I've answered your questions. I really appreciate your attentiveness, and I hope you have a fantastic weekend. And I look forward to seeing you guys in a couple of weeks. There's somebody else had one last question. It's so about flare post-cataract surgery alone. So flare alone, yeah. So when I say flare, I'm not talking about a flare-up of inflammation. Flare is proteinaceous flare, and there's no cell. So patients who have proteinaceous flare pre-operatively have a long-standing uveitis, okay? And those patients, in my opinion, are the ones that are going to have more post-operative problems with their intraocular lens, more likely to cocoon, more likely to develop hypotony, more likely to develop cystoid macular edema. That's what I mean. So that is an important sign of uveitis to be aware of, and it's something that would be important for you to consider in your surgical approach. Well, would you use intracameral medication for pupil dilation? You can if you think you're going to be able to dilate the pupil. Sometimes you can't because there's chronic synechia. In the non-uveitis patient, Dr. Al-Bakri, I don't know if I got your question right. I'm sorry if I didn't. But if you have, just flare in a non-uveitis patient, again, those patients may have a little bit more proteinaceous exudation. There has to be some good reason why they have that flare. But temporary flare, that's not going to have any kind of major effect on the postoperative outcomes in non-uveitis patients. So, so thank you very much for your attention. I look forward to seeing you guys in 2 weeks. We'll talk about glaucoma in a similar approach. It won't be quite as long a lecture, but we'll certainly open it up for questions. Thank you. Thank you.